Hi, my name's Sue McCarthy Robinson. Wanted to spend some time with you today and do my recording on the interaction between the transference, the counter-transference, and the prejudice, biases, or judgments that we're making about patients that are verbalizing possibly about me, in a session, that I've encountered could have encountered this week or did encounter this week. Um, so talking about, had many experiences throughout, not only this week, it's happened and throughout my clinical experiences, and even prior to clinical experiences where just being as a nurse, just taking care of patients. So just talking about, working with the patient during sessions, I have experience where have expressed feelings that seemed, had a patient seem disproportionate, to our interaction, where over time I realized the patient was really, I'd say, engaging in transference, where projecting feelings from maybe past relationships onto me as the healthcare provider. They saw me maybe as a motherly figure. There's a lot of patients that I'm, interacting with that are ages of my sons, in the 20 or something, 30 something year old. So I think sometimes they do see me as that motherly figure. So inherently, this may not be a negative thing, but it can skew the therapeutic interactions. So at the same time, sometimes I'll start to notice that counter-transference on my part. I begin to feel really protective of the patient, which, sometimes it may make me more lenient in enforcing boundaries such as medication adherence. This is an emotional response that I hadn't recognized immediately. Also realize that there are subtle biases at play coming from a different cultural background than my patient. I initially will sometimes assume about their family dynamics that impact my judgment. These biases stem from my own upbringing and cultural norms, that I grew up with, but I quickly recognized the need to set those aside. Patients can also express biases towards providers. They may think that, well, I haven't experienced maybe some bad things at all, or, that I'm a professional and that I haven't had, anything's bad happen to me. So in this case, they'll verbalize that concerns about my ability to understand their struggles, due to their cultural differences or what's happened to them. They seem to assume that I couldn't fully empathize with them, which affects their trust in the relationship. So, the origin of these issues, these dynamics, transference, countertransference, and biases originate from both personal experiences and societal, conditioning. The transference also rooted in those unresolved emotions from the patient's past relationships. The countertransference, on the other hand, stems from our own unresolved, issues as providers. Those prejudices and biases can be shaped by cultural, social, and even familial influences that we all carry, into our professional roles. Continuing to provide care. So would it be appropriate to continue providing care to this patient, if I couldn't kind of check myself? This case, I was able to check myself and, with the conditions and recognizing the dynamics that play with actively managing them. For instance, once I became aware of the countertransference, I saw supervision reflected on my emotional responses, which helped me kind of recalibrate things and enforce the necessary boundaries. I addressed the patient's concern by openly discussing cultural differences and reinforcing that while our backgrounds may differ, my goal was to provide compassionate and culturally competent care, not being judgmental at all. This transparency helped rebuild that trust, preventing any any issues from negatively affecting care, it's important to engage in that self-reflection and seek, the supervision and advice when needed. Also found that clear communication and boundary setting helps maintain that professional and therapeutic relationship with that patient. Regular self-awareness, and reflective practice can mitigate the influence of personal biases and emotions. By acknowledging these dynamics early, I can foster a more balanced, therapeutic relationship, ensuring that the patient receives that best possible care. If I'm not able to, recalibrate, as I say, it would be best for me to, put that patient into someone else's hands that would do better by them, So in conclusion, the transference, countertransference, and biases are common, in the psychiatric practice, but addressing them, proactively, we can create a more effective, and supportive environment for our patients. It's about really balancing empathy and professionalism, maintaining a reflective practice to ensure that we're offering the best care possible. We owe that to our patients that, we're being entrusted to. Thank you.